Okay, today I'm going to take you on a very different trip, which is called optic atrophy. And basically, it's a misnomer because there is no atrophy here involved. And optic atrophy is not a diagnosis at all. As you can see, I have no financial interest being a neuro-ophthalmologist, but there is a very nice story with this slide. This is a young beggar in London with his cup and reading Marx Capital. You know, I have seen so many similarities with this young guy, so I put it into my disclosure statement. Okay, so I will start with an index case of a 50-year-old male whom I've seen lately and who was referred to me due to an incidental finding of bilateral optic atrophy on a routine eye exam. On examination, his uncorrected visual acuity in the right eye was fantastic, while in the left eye he was seeing only 0.4. His color vision, of course, in the right eye was perfect. It was not that perfect in the left eye. He had a left trace RAPD on the pupillary exam. And on the fundus, as you can see, he had bilateral pale optic discs. And his OCT RNFL showed an average thickness of 49 in the right eye and 36 in the left microns. So it was an optic atrophy, of course. As always, we ask questions these patients, and on additional history, he told us that at the age of 13, he was hospitalized in the same hospital for headache, diplopia, and blurry vision. And on examination, he had bilateral optic disc edema, a normal brain CT, visual field loss, and opening pressure of lumbar puncture of 210 millimeters. Interesting. Do we know the reason for his optic atrophy? Not really. Could it be post-papilledema? Could it be labors? Could it be post-AION? Could it be post-optic neuritis? I don't know, because I haven't seen him back. But with this, I would like to open the session of my talk on optic atrophy. So as I told you, optic atrophy is a misnomer, and optic atrophy is not a diagnosis. Optic atrophy is actually a final common endpoint of many disease processes that can cause loss of some or most of the fibers of the optic nerve, or it can be a congenital condition. It generally manifests as a change in color and structure of the optic nerve in association of visual dysfunction. And you probably all know the manifestations, which are decreased visual acuity, decreased contrast sensitivity, depressed color vision, RAPD, whenever it's unilateral. Whenever it's bilateral, it can be no RAPD. Visual field defect or visual field defects, and it can be central, it can be peripheral. And of course, additional findings like proptosis, strabismus, headache, and skin changes. And I just want to remind you that optic disc atrophy develops in about 6 weeks, sometimes more, following an optic nerve lesion. And while being solitary, the optic atrophy is a fast localizing sign. Now, the usual list of etiologies of the optic neuropathies that can convert into optic atrophy is very well known to you, of course. And I will repeat it, although we had all day been dealing with them. It can be demyelinative, inflammatory, infectious. It can be traumatic. It could be ischemic, hereditary, GON or glaucoma. It can be compressive, and that's the most frightening reason that we generally meet. It can be neoplastic, it can be infiltrative, it can be due to increased intracranial pressure, and it can be, of course, toxic and nutritional. Now, you all know that the correct evaluation of the optic atrophy is very, very important for the diagnosis of the ocular systemic diseases. And we as ophthalmologists should be very, very careful in not writing optic atrophy, but seeking the real diagnosis. We are aware of multiple classifications and subdivisions of optic atrophy, and most of them, which you use in your daily practice, can guide you into the correct and final diagnosis. I will give you one or two of the classifications of the optic atrophy, starting with what's called primary, secondary, and other optic atrophies. In primary optic atrophy, we all know that there is no antecedent swelling of the optic disc. The lesion is generally between the retrolaminar optic nerve and the lateral geniculate system. This is how the optic atrophy in this primary optic atrophy group looks. The causes are various. You can have optic neuritis. You can have compressive reasons, the classical toxic, nutritional, and hereditary causes. You can have demyelinative causes, traumatic causes. And remember that the temporopellar of the optic nerve can be due to atrophy of papillomacular bundle, and also that band atrophy can be due to lesions of the optic tract. Now, secondary optic atrophy is when there is procedure by long-standing swelling of the optic nerve head in cases like atrophic papilledema, for instance. The disc generally is raised, has a very dirty, white grayish color. The margins are poorly delineated, and the lamina cribrosa is obscured. You can find pattern lines, and there is sheathing of arterioles, and this is how it generally looks. Also, we can see secondary optic atrophy in cases like NAION or non-arteritic anterior ischemic optic neuropathy, papillitis, or neuroretinitis. There is also consecutive